Hello, good morning, good afternoon, and good evening to everyone coming to this virtual education series. My name is Dr. Deepak Ravindran, and this particular workshop is going to be focusing on living with pain, the perspectives of patient living with long COVID and pain, and a clinician's perspective in seeing how we should be helping our long COVID patients. I'm a consultant in pain medicine working in Reading in Berkshire, United Kingdom. And I've got my specialist physiotherapy colleague, Harriet Wilkinson, with me. But more importantly, we've got two patients struggling with long COVID. One of them is Kerry Thornhill, who is going to be a pain sufferer, but has also been struggling with long COVID for the last 18 months and chronic pain for almost 30 years. And then this will be followed by Karen Matthews, who is a campaign member of the patient support group Long COVID SOS. She will be talking to us about her experiences of long COVID for the last 20 months. And then you will have talks from my colleague Harriet Wilkinson and her experiences of physiotherapy for long COVID. And finally, I will be talking to you about what it has taken to set up a long COVID service in the United Kingdom, the first country in the world to actually set up such dedicated services as far back as November 2020. So kicking it all off will be Kerry Thornhill, who will be presenting her perspective with living with long COVID and chronic pain. Thank you, Kerry.
Hello, my name's Kerry. I'm a coaching psychologist and I've been living with pain for 32 years. And I also have COVID pain as well, which I've had for nearly 15 months. So as I just said, I have 32 years of chronic pain, and the previous pain has been mostly musculoskeletal. I have Ehlers-Danlos syndrome type 3, so I'm very hypermobile. I have lots of joint instability and I have nerve pain. But in the months before COVID, I was able to attend a specialist gym for about an hour and a half twice a week with 5-minute spurts of exercise on each machine. I was improving quite well. I'd reached a stage where I could walk easily, because back in 2008, I was told I'd never walk again. So it has been quite a journey from immobility to being mobile with all of those disabilities and pain. EDS also, Ehlers-Danlos syndrome, EDS, also causes postural orthostatic tachycardia syndrome, which I'm sure many people have heard of, which is caused by the collagen laxity in the blood vessels, and that has been badly exacerbated by COVID. So as you see from the picture there, this guy has pain in lots of different places and trying to hold on to it. And what I found with COVID pain was that I don't know which bit of myself to hold first. So much of it hurts. It's not isolated to one place anymore. Previously, it was my pelvis. I sustained injuries to my pelvis ligaments when I was 12, which made the EDS, that was back in 1989. And the EDS made all of that a lot worse, and that's where I became very unstable. But it was isolated to my pelvis with compensation injuries, whereas now my pain is increased at least tenfold. You don't know which area of your body to address first. The whole of you hurts, and you don't have enough hands to hold all of the bits of you that you feel need holding. It's a very natural thing to want to hold your pain, but with COVID you can't because there's so much of it. And the best way I could describe it is it has resonance. If it was a sound, it would be like a bell that doesn't stop chiming. A little bit like the old-fashioned cartoons where a bell fell on the character, the bell would be struck and the character would come out very, very wobbly and clanging. I'm not sure whether that's nerve pain, because it does almost feel like every single nerve in your body has come alive all at once and is quite overwhelming. And because you don't know where to put yourself, because you don't know which bit to hold first, there is no comfortable position. It hurts to wear clothes. And you can't sleep. There is no comfortable position to sleep in, so sleep is very sporadic. I have a lot of rib subluxation because of the breathing difficulties I've had. I was on day 17 of my COVID symptoms. I was ambulanced to the emergency department at my local hospital with breathing difficulties. And it was largely ignored. They just said, well, your oxygen's fine. Of course, my oxygen was fine. I was compensating by overbreathing. But the overbreathing, the improper breathing pattern that occurred as a result of all of that has led to rib subluxations. It's led to lots of costochondritis. I'd had that for a lot of years and it had gone away. I was overjoyed it had gone away. And now it's all back again on the left side, the bottom of my rib cage. And I can feel that there's a rib that sits very proud. My physiotherapist won't do anything about it. She says it needs to settle in time. I have an enormous amount of fatigue. I previously recovered from ME chronic fatigue in 2013, where I was almost bedbound for about 6 months. I wasn't as bad as some, but on top of everything else I was dealing with, it was more than enough. The fatigue now feels slightly different. Before it had a clarity to it. If it had a colour, it wouldn't have had one before. Now the fatigue feels very murky. It's almost a khaki colour. It's very, very heavy, very leaden. So COVID fatigue does, to me, feel different from ME fatigue. And the worst thing in the world at the moment is social interaction. It's enormously draining having to be present for other people for any period of time. It is incredibly difficult. I can maintain a conversation for just about an hour, but that means that I have to take the rest of the day off and the following day. And I have to allow for that in my schedule, which isn't handy when you're trying to work. The biggest problems I've had when it comes to dealing with all of this is the inability to access support. In the UK, we have the National Health Service, the NHS. And when I was in A&E, or the emergency department, as the Americans call it, he looked at me and said, "You're overbreathing, that's anxiety, go home and be less anxious." I had 3 out of 4 signs of viral sepsis and I was sent home after 4 hours. Getting back into support then, when your primary care practitioner won't see you in person, where everything's done over the phone, is incredibly difficult. They can't see you, so they can't take you seriously. You can complain about your symptoms and all you get is this, "Oh, well, it's a virus, you just have to ride it out," which was what one of the doctors said to a paramedic who came out to see me about a month after my ED visit. And it's not really good enough, to be frank. When you do get into a hospital, you encounter a lot of resistance from medics. You're very much time bound in the appointment. You get 10 minutes, 15 if you're lucky, and that's not enough for them to hear about your symptoms. Everything they do is very compartmentalized. So your cardiologist is busy looking at your heart But when you have postural orthostatic tachycardia, which is an electrocardiological problem, it's a bit of a mouthful, they don't look and say, okay, that electrical signal is coming from your brain. What might be going on in your brain to influence what's going on in your heart? So there's no joined up holistic thinking between different parts of the body. It's far too compartmentalized. And because of that, there's a lack of curiosity. They don't want to look. It's almost this attitude of, if we don't look, we won't see. If we don't see, we don't have to spend any money. And that's an enormous problem. They're busy juggling budgets, so you become a number, and attached to that number is a series of pound signs. And it's, I've only got this amount of money to spend on people. I might have to spend more on you than I can spend on someone else. And it shouldn't be like that. It should be about the person. It should be about helping improve their quality of life. It shouldn't be about the pounds, the dollars, and where is that going to come from? And the other thing I noticed was a distinct lack of curiosity from the medical profession. It's as if they don't want to know. They've been presented with this enormous problem, but they're not saying, you could go to this research program, you could go there and go to that researcher. This person would be interested in your symptoms and your story. And these things don't exist. So you've got compartmentalization on top of almost this ignorance that feeds the resistance that says, I don't want to have to do this. And then you hear comments like, we have no protocol for this. So there's no procedure, there's no set of boxes they can tick that says they've dealt with all of this. It's just, oh, well, I've got what I've got. But sometimes you need to explore more. And I came across an article last year. I think his name is Professor Fergus Gleeson or something like that. He came from the University of Oxford, and he did a study on, and I think he found it quite by accident to start with. He looked at the lungs of people who've had COVID, where their MRIs and their CT scans were clear. And he had them breathing xenon gas at the same time as they had their MRI. And he found that in 8 out of 10 of them, they had a much finer, deeper level of damage. His study was very small. It was only 10 people. And they've said it needs to be done on a larger scale. I've volunteered myself for it straight away, because I still have breathing problems and oxygen saturation problems. Do you think you can get a xenon MRI out of the NHS? You won't. They simply don't do it. It will cost too much money. Who do we do it to? Why do we do it? When will we do it? When will we follow up afterwards? What do we do once we've got the results? It's this, we have no procedure, so we won't deal with it. Not just we can't deal with it, it's we won't. And it's enormously restrictive, and it causes lots of communication misunderstandings. And on my screen there, you'll see 2 leaflets from my friend at Stickman Communications, Hannah, where she's created these leaflets about misunderstandings that occur between patients and medical staff, because they use one set of language and the patient interprets it as something different. And where they're interpreting it into their symptoms, it comes up with, but you don't understand what I'm going through. And this is something that comes up an awful lot, whether it's in rehabilitation, whether it's in pain management, whether it's with a consultant looking at your symptoms generally. This lack of communication is a really big issue. I've touched on money already, but you then have issues with, do you go to the NHS for your treatment? If you do go, you're facing an incredibly long waiting list at the moment, because everything else has been shelved for COVID. and they have waiting lists and delays of at least 2 years in most cases. So do you then self-pay? It's rare that we have medical insurance in the UK because we have the NHS. So do you self-pay? There are some things that you can't get from the NHS. And do you participate in research to find some more answers? I participated in the cover scan research where they're looking at COVID and the damage it's caused to internal organs. And I participated in that because it was the only way I could find out what was going on in my body. And the lack of time. You have a 10-minute appointment and there are often too many symptoms with COVID and long COVID. Long COVID now has over 100 different symptoms. And you can't deal with all of those in 10 minutes. So what's working for me at the moment, it's rest, rest, and even more rest. It's listening to my body. I get no warning that I'm about to crash out. I might feel a bit rough and a bit ropey, and I think I need to sleep. And I get about half an hour to have shut everything down and be laid down in bed, and then I'll sleep for an extra couple of hours. It can be very inconvenient. It's not the most helpful thing in the world, but it's what I have to do, and I have to allow time in my schedule. If I'm going to sleep, it's normally late afternoon or it's during the evening. Pacing activities are key. A lot of people with chronic illness have heard of spoon theory. So each spoon represents an amount of energy for each thing you do. Some of those spoons get used up. So you only have a certain number to go through in the day. If you burn through them all in the morning, you will be exhausted by the afternoon, even more exhausted by the evening. If you still have things to do, you're borrowing from tomorrow. And then you have less for tomorrow. So it is about learning your triggers, learning what drains you. So for me, I said that was social interaction. What else is a trigger for me? Working at the wrong time of day is also a trigger. If I do far too much, far too soon in the day, I will be done very, very quickly. And I'll be ready to sleep by 4 o'clock in the afternoon. It's about learning those. It's about learning to manage those. It's about planning and pacing what you have to do during your day so that you can manage. Gentle exercise, short walks, things like Tai Chi, things that are non-taxing. Yoga is difficult for me because of the bendiness and trying to time the breathing at the same time as moving. That's still not easy 15 months on. But yes, so very, very gentle exercise, but still listening to your body. If you're having a bad day, maybe you won't do as much. If you were doing 5 minutes, you might just do 2. Supplements have been huge in all of this. As a regular, I take collagen supplements, hydrolyzed collagen. I take a strong multivitamin, and I take high quality strong fish oils. Those are my regulars. I've added in other things. I've added in extra vitamin C, extra vitamin D3. I've taken various things to help with breathing patterns. Those help to normal sleep, but they're not to do with pain. The other important thing I think for all pain management is to be nutritionally vigilant. So this again ties in with learning your triggers. There might be some foods that make you worse. There might be some foods that make you better. For me, foods that make my fatigue and pain worse include nightshades, so potato, tomato, things like that, but those two particularly, peppers, chili. So keeping a slightly blander diet has been quite useful for me. A lot of people talk about being high quality vegan, I can't eat dairy anyway. So for me, it's about lean white meat if I'm going to eat any at all. Perrin technique is working well for me. This is a combination of lymphatic drainage, self-massage, and cranial osteopathy. That's not available on the NHS. I have to pay for it myself. It's going to be a long haul. It's designed to flush out your lymphatic system and the remnants of the virus that live within that, particularly within your brain. And it does trigger the pain symptoms sometimes. And it does make me incredibly tired after a treatment. But it does seem to be having an impact. And I've only been doing that for 2 or 3 months. And the other thing is to avoid long social interaction. Anything that goes over an hour, I have to stop and say, okay, I'm done now. I hope you don't take offense. This is about my health. This is not about you. And just keeping the boundaries on time and making sure it doesn't go over my limits. And there's a nice quote here that came from Dr. Perrin, who created the Perrin technique, where he says, whatever activity you feel capable of doing, do half. And that ties in with some of the advice I was given on Deepak's pain management program, where you're working up to your threshold, but not beyond it. So if you're working at half, as you're improving, your threshold will increase as your half increases. And that's the theory behind that, and it does work. So that, I believe, is my story. What needs changing? We need better listening and questioning skills from doctors. Whether it be counselling skills, whether it be coaching, training, so they can actually get to the information they need instead of having you talk for 10 minutes and say, thank you very much, this is the end of your appointment, off you go. It's to have individual understanding of each person and their range of symptoms, because everyone is so different, instead of trying to get you to fit into a nice little box. There need to be research suggestions promoted to the patients. At the moment, most of the research suggestions are coming from social media groups where the research programs are being promoted. The doctors need to be far more active in that, to be able to push people to places where this is actually going to create some good data. There needs to be some joined up thinking instead of compartmentalizing the body, to take a more holistic view, because one thing can impact the other. COVID has enormously impacted the autonomic dysfunction. I have issues with dehydration now. When I'm drinking vast amounts of fluid still, I can drink up to 4 litres of fluid a day and still show signs of dehydration, but everyone looks and says, we don't know what that's about. And you think, okay, so find out then. No one wants to. So we don't know, it's COVID. And there needs to be better multidisciplinary support, better communication between the different departments to see if the missing links from COVID can be found. And it reduces the number of appointment visits for patients as well, because all of the travel to hospitals and everything else is exhausting. So that is my presentation. Thank you very much.
Hi, my name is Karen Matthews. I'm going to speak to you today about living with pain, long COVID patient's perspective. A bit of background about myself. I have suffered acute episodes or time limited periods of pain in the past. So I've previously injured my leg and it took a month to recover. But since my probable COVID infection in March last year, I've been left in chronic pain, which is something that I've never experienced before. And the perspective that I'm giving as well is that I'm in the UK, we have long COVID clinics that have been set up. I am not currently within one of those. I'm on a referral list to be assessed by that service. So I'm basically doing this on my own with a little bit of help from my GP. So this is how I kind of see the cycle that I'm in at the moment. Sleep appears to be really crucial and critical for the amount of pain that I suffer. And movement, if I have to sort of get the sweet spot. If I do too little, I'm in pain. If I do too much, the pain increases. And if the pain gets too constant, it will interrupt my sleep. And then I have to, if I have a couple of nights of that, because everything starts to get worse when I lack sleep, I generally take some codeine that I've been prescribed so that it takes the pain away enough that I can actually get some rest that night. And the pain that I feel is of different quantities and qualities. So sometimes I feel it all around my body. Sometimes it will be kind of just in one area. It's in my muscles and it's in my joints. So sleep, as I said, is really critical. And I kind of imagine that I would like a sort of stasis chamber to help me sleep at times. And I saw this picture of a bear in water, and that's exactly what I want. I've introduced to a number of people that I know the idea of a jelly bed, so that I'm held in suspension and on no touch points with my bed itself. It's really incredibly hard to rest when actually the lying down to rest actually causes you more pain as well. I do find that some nights that I wake up and I will be crying out in pain, or I'm just sobbing, and they are really horrible. So sleep is just so important. And then when I wake up in the morning, there is no such thing as a rapid rise from my bed anymore. It takes me approximately 1 to 2 hours after waking up that I can actually start moving around the kind of house. I'm like the slow zombie in the morning. I have to gently get my muscles going. And I use that time in a way to let my body tell me where it is that day. Or I just fill my time in other ways, like looking at my smartphone or just watching something, and just accepting that that is going to take me a little bit of time to just wake my whole system up. It's quite an extraordinary experience, being in my 40s and actually feeling like what I imagine a 70 or 80-year-old woman feels like. So quite soon after waking up, I try to start moving around. And one of the most popular ways I do this is I go out for a morning walk. And this is what I look like. Well, this is a bad drawing of what I look like. Shoulders back, good posture, walking quite confidently. Sometimes I like to imagine myself as the bus in the movie Speed, because I somehow find it easier moving faster than slower. It's harder to move slower for some weird reason. That is how I actually feel on the inside. I'm like hustled over like an old woman on a cane. And actually, that is the image that I have in my head when I'm walking in pain, because visualizing how I'm actually feeling helps me do what I do. And it's almost that I have to accept and hold the pain to actually deal with it. I don't think trying to ignore it or push through it will help me. And I like to think that because I was quite active before this happened, that I actually have some kind of experience of moving when you're in pain, or just, you know, you're feeling uncomfortable, let's put it, and actually learning how to recognize when your body can push through something or has to kind of hold back, and it's reached that point where you need to stop and rest. So I hope that that's the case, but as I said, I'm not under any clinic or anything, so I'm kind of guessing this as I go along. Other ways that I use to like kind of manage myself and manage my pain load is hot water. So I will take baths with salts in them to try and ease the pain sometimes. And it's a really bad drawing of a hot water bottle, which is another method that I use. But conversely, it's not just the hot water that I use. I also use cold water showers, which also seem to help. And also I sometimes go cold water swimming for a bit, because it just seems to help with the pain. Other things that I do is I gently stretch. So there's a picture there of someone doing child's pose in yoga. I do quite a bit of yoga to stretch everything out, because I think trying to remain as flexible as I can is important, because I think if I start adapting the way that I move because of the amount of pain that I'm in, that it's just going to make it worse, and it's just not going to help the future me. So I'm kind of investing in future me by doing these things, even though they're not comfortable. And the other thing that I do is I do a bit of meditation, and I do that sometimes when I'm doing that 1 to 2 hours in the morning, trying to get up. It's not as beautiful as that woman there sitting on the tree trunk, but I often do have visualization of mountains and moorsides and coastal treks that I used to do a lot more than I'm able to do now. So that kind of helps me as well. It kind of gives me an aim to where I want to try and get again. And this quote, I don't know if any of you've read the Hitchhiker's Guide from the Galaxy books. There's a cow in the restaurant at the end of the universe who comes and introduces himself to the gang and asks which part of himself that they would like to eat for their evening meal. And that's kind of, I feel like I'm meat tenderizing myself when I use my massage rollers. It hurts, really hurts, but it does seem to give me some relief again from the pain. So it's kind of, it's something that I do, but it is kind of a chuckle that I feel like I'm tenderizing myself and hoping that somebody doesn't want to cannibalize me or anything like that. But it's just, I just find when you're in like the amount of pain that I have to live with, that it's actually when you can get those, laughter in itself is a cure. So if you're doing these things to help the pain, it actually makes it easier and kind of gives you a bit of relief in that way as well. And I thought I'd leave you with this slide, because I find that fatigue is always shadowing and almost stalking the pain. The more pain that I feel, the tired I am. The more pain that I feel and the tireder that I get, the harder that everything gets in that day. And the more that cycle gets longer and the more it gets worse. That's why with the sleep, and I said I'd take the codeine, I only tend to take pain relief before bed, but that's the cycle I want to break, because just tiredness and pain together are just really hard to handle. And I put that sort of statement up there in because a lot of people talk about illness and conditions people have, and you've got to fight this, you have to succeed and beat this, and actually the pains in my body I hope is recovering, and the chronic pain that I'm in at the moment is not going to be something that is going to be my life forever. That's something I'm holding there. And therefore, if I'm trying to beat the pain, I'm beating up myself, and that's not going to help in any way, shape or form. So I hope that you found that interesting, and I will take any questions in the Q&A.
Hi, my name's Harriet Wilkinson, and I'm a specialist pain physiotherapist that works at the Royal Berkshire Hospital, and I work in the Berkshire Long COVID Integrated Service as a physiotherapist as well. And I'm here to talk about pain, fatigue, and long COVID. So the way I assess within the long COVID service is very similar to how I would assess in a pain service. So first of all, I want to assess all of the symptoms that the patient is experiencing and the impact that they are having on them. So are there any underlying pathologies that can be causing an increase in the symptoms that we can actively treat? So for example, is there a vitamin D deficiency showing on their blood tests that we might want to supplement? Or has the COVID virus perhaps dysregulated the body symptoms? So that's quite important for us to know. The other thing is the current level of activity and the symptoms associated with it. So what is the patient currently able to do? And are there any flares and symptoms after or before the things they are doing? So are there any aggravating or easing factors? Or is there a pattern to their symptoms? So are they noticing a boom and bust in their symptoms? Are they noticing when certain activities are causing a flare in their symptoms? So just getting a real picture of what is going on with this patient. Now, I've put pain versus fatigue, or is there pain with the fatigue? And the reason I look at this is because are there persistent pain symptoms that perhaps have flared, and therefore fatigue is as a side effect, but there's no real post-exertional malaise? Or are there symptoms of post-exertional malaise? And I'll go on to a little bit more about what I mean by this in a little bit. And also, more importantly, what does that patient sitting in front of me most need help with? What are they most struggling with? What do they need support for? And is their mental health being affected as a side effect? We know these symptoms can severely impact life. So do I need to signpost to other services? Do I need to support them with the mental health and the significant impact that these symptoms are having on them? So one thing we look at is what management strategies are they already using? So you'll hear from one of our patients within both of the services today, and they've already been through a pain management program. So actually they've got a few of these strategies already, and so they might already have a very good understanding of them, and therefore they might just need topping up with them. But they might not be using any. So it's really good to know from the patient what is working and what isn't working. And these are just a few things they might be using. So are they using pacing already? Do they know what matters for them? Are they finding breathing and mindfulness useful? Have they got any soothing activities that help with the sensitivity of their systems? And are they using medications? And also, do these medications need to be reviewed? Because we know alongside the pain, fatigue is having a significant impact on these long COVID patients. So with pain and fatigue, in pain management, pain isn't always the best indicator of too much activity. So one of the things that we do within our pain management programs is teach people to recognise various body signs and symptoms that might indicate overactivity, because often pain isn't the best indicator. So this might be changes in heart rate, or their breathing pattern, or muscle tension, or any thoughts, feelings, or emotions that are contributing to this. So depending on how the patient was managed, so for example, if they had an ICU stay or intensive care stay, there might perhaps be some level of muscle deconditioning. And therefore, some of these pain management strategies that recognise the body signs and symptoms might be useful to help them gradually build activity. However, what we've mostly found within our clinic setting is the patients coming to see us with pain and fatigue are the patients that have been managing in the community, perhaps had fewer symptoms at the start of their COVID virus. However, their developed symptoms are having a significant impact on their life. And these are often persistent pain combined with fatigue. So with long COVID, increases in fatigue may be an indicator of overactivity or pushing through, but we would want the patient to recognise their signs and symptoms before this increase in fatigue, so that they can help manage that, they can help manage these flares. So like with pain management, we'll get them to recognise their other signs and symptoms and not just the pain or the fatigue. And recognising that the individual's own signs and symptoms before increasing activity is important, and recognising the impact it is having on their lives. So I've mentioned post-exertional malaise briefly, and post-exertional malaise is the worsening of symptoms even after the smallest amount of activity. However, this can often be 12 to 24 hours after the activity, even if it's a tiny amount of activity. And I've put some of the symptoms that people might experience up here. So fatigue, brain fog, muscle aches and pains, palpitations, sweats, and there are many more. But one of the reasons patients tell us that pacing is so difficult is because often you feel okay while you're doing the activity, but actually the symptoms come on a little while afterwards. And so developing and understanding the pattern to their symptoms can be very difficult because it's variable from person to person. And it's really important to understand the difference in all of these symptoms. So with pain and long COVID, we run a pain management programme at the Royal Berkshire Hospital called the Explore Pain Management Programme. And within this, we'll talk about a various different array of things to help them manage their pain. So we'll talk about the science behind pain and how to increase and decrease sensitivity, what might aggravate and what might ease their pain. We talk about what helps them and what definitely doesn't. And we might set goals alongside the things that matter and base an activity diary around this. And we'll talk about this boom and bust cycle we've talked about. So the human nature wants to do things when you're having a good day, which actually might mean that you have a bad day following it. So trying to break this cycle. And there are many similarities of managing pain in a pain management setting and managing pain in a long COVID setting. However, I think there are a few differences. So the similarities are that we still want to understand what's important to that patient. We want to identify the things that we do know about long COVID, but actually there's much more research to do out there. We want to understand the aggravating and the easing factors for the patient. However, we might step away from the goal setting a little bit more and focus on the pacing. So what level of activity are they able to manage in this present moment? And how do we monitor for those symptoms of post-exertional malaise as we do this? And that can be really difficult because these can have a significant impact on the patient. So increasing movement with pain management can be really important alongside goal setting, because it's thought to then decrease the sensitivity of the nervous system by using all of these tools and strategies. However, with long COVID, flares and pain might be present, but often alongside this, there's often flares and their fatigue. And if fatigue is their main driver for their symptoms, actually often it's the body's way of saying that they need to stop and slow down. And this is incredibly difficult. And we often hear within our clinic setting that this level of activity is significantly lower to what they're used to. And that can be very, very difficult. But actually, perhaps goal setting isn't the most imminent priority, and actually getting an even baseline to allow the body recover might be. And this is what I mean by pacing. So we might ask the patient to fill out an activity diary in the day or in the week, and ask them to make note of any higher level of activity, low energy levels of activity, and any restful activities they might have within that day. And alongside this, they'll make note of any signs or symptoms: brain fog, fatigue, increases in pain, increases in muscle tremors, anything to pop on there, because this will help them recognise that post-exertional malaise, those delay in symptoms that we've been talking about, so that they can plan their week based on their new current level of activity that is manageable for them and their pain and their fatigue and their body. And it's not just the physical. So it's important to note that it may not just be the physical, but also emotional or cognitive fatigue. I think it's important to recognise that it's not easy, and there's a real burden on the array of symptoms, as they can be quite extensive. I think it's human nature to want to push through the symptoms experience, whether it's the social expectation or the need to return to work or the comparison with our past selves because their activity has probably significantly changed. And we've often heard patients say in clinic, I should be able to, or I used to be able to. And perhaps actually that might be what it might be pushing them through activity because it's what they're used to do. And management of these symptoms can be very difficult, and I believe it should be person-centred and supported by a team. And this team should be made up by the patient with their family, their friends, any healthcare professionals they think might be valued in that. And the patient should be at the centre of this journey. As a physio, I'm certainly taught to be very goal-orientated, to set one goal and then increase it and then increase it and then increase it until your body's adapted to that. However, what we're noticing is actually with long COVID, we can't necessarily do that. And we've got to allow the body to settle and the symptoms to settle. And then we might both be gradually able to increase activity based on that. But it's not just the patient being lazy, it's the body's way of saying, I need to stop, and acknowledging the impact that has had on their life so far. Return to work is difficult because there's no simple formula and it requires individualisation. And it may need to be adapted based on changes in symptoms. So again, we've had patients coming in that have returned to work and they've had a bit of a relapse and remitting type of presentation. So they've managed to get back, and then perhaps one thing has triggered a flare and they've had to perhaps start a little bit more again. And it's really important that we try and support patients through this and try to support their workplace as much as possible. And unfortunately, there's no quick or easy answer to it. But really, the aim that we have in the Bliss service is to provide hope and support. So unfortunately, we can't predict the future. And it's important to just try to take one day or 1 week at a time. And with good management and support, we've seen good progress with pain and with the fatigue alongside it. But that's why it's important to manage the variety of these symptoms that are having an impact, because everyone is an individual and it's having a huge impact on people. Thank you very much.
Good morning, good afternoon, good evening to all of you who have joined this presentation from various parts of the world. Thank you to IASP for giving this opportunity to present about our service, about our experience with long COVID. You've already heard a few of my lived experience patients and also my physio. And as the lead for the service here, I'm going to be talking about what are our thoughts when we want to design a long COVID service. In your place where you're going to be asking these questions, it's quite relevant to think about trying to build a service from the point of view of patients. And that's what I want to bring across to you in the next 10-15 minutes. I'm the clinical lead for the Berkshire service here in the United Kingdom, and I'm a consultant in pain medicine, anesthesia and lifestyle medicine, and I work in the Royal Berkshire NHS Foundation Trust in Reading, United Kingdom, which is about 20-30 minutes west of Heathrow Airport for those who are curious. I'm also the lead for one of the community services here, and I'm a published author for a book around pain management released earlier this year. So effectively, what we want to look at when we want to design a service is actually to start from the ground up. And in this position, we had the real good fortune to be working with one of the support groups for patients with long COVID in the UK called the Long COVID SOS group. And we reached out to them and asked, what is it that they would like from a service? And these are kind of the 10 top points that they told us, that they wanted breathlessness for the symptoms of support for the symptoms of breathlessness, dealing with cognitive disturbances and brain fog, advice regarding joint pain, muscle weakness there, and actually consideration of hormone imbalances, sleep problems, nutrition and inflammation related issues there, counseling for mental health or any kind of PTSD like symptoms, especially if they've been in ICU or been hospitalized. And of course, some kind of support around task management, access to peer support services, other people who are struggling with their symptoms there. And last but not least, the diagnosis or support of chest pain or autonomic dysfunction and those symptoms that come under the bracket of postural orthostatic tachycardia.
So these are their top items there. And we realized that we had to incorporate, not all of it could be provided in every service, but the NHS as a whole, we were given some guidance which allowed us to make that decision. We know that with long COVID, these are the numbers in the UK that we were dealing with. At the time of giving this presentation, we have more than 4 million positive cases. We definitely are seeing the back of the second wave and the third lockdown in that sense. We've had a scale of mortality which has been quite high for a Western nation there. And we realize that long COVID now is not your typical viral infection with everybody becoming all right after 3 weeks. Long COVID has shown that it is a multi-system impact. You've heard the versions from my other patients, Kerry and Karen, in terms of how the symptoms have evolved and what they have. So it's more than 20 symptoms that have been talked about. There's also this difference between patients who've been in hospital, not showing enough of the symptoms there, whereas the non-hospitalized ones seem to be considerably struggling with long COVID. And those have all an outcome and impact on the prognosis and what their final outcomes are going to be. So with long COVID, we realize that actually it is worse. As far as the UK data is concerned, 1 in 10 people are supposed to, those who tested positive are exhibiting symptoms for 12 weeks or longer. 1 in 5 if you take 4 weeks as the cutoff point there. And our most recent data, which came in April 2021 from the Organization for National Statistics, which is a landmark organization in the UK, said that 1.1 million patients probably have symptoms lasting beyond 4 weeks there. And healthcare workers and teachers are actually more than 250,000 together, almost 250,000. So that is a fair sized population having and struggling with symptoms. And even the data that seems to be coming out seems to be saying that 7 months post-acute COVID-19, up to 45% are on reduced work hours. So this is a major impact on productivity and economy in any country that you're listening, and including this might be the same in your country as well. Well, post-COVID syndrome is not an unexpected phenomenon. We initially thought, well, is long COVID entirely new? It is new in the context that some of the systems that it is affecting is probably not being seen with other post-COVID sequelae to that extent. Maybe it's the fact that it's a pandemic, so a huge number of people are coming in one go in many countries. But post-COVID or post-viral syndromes really have been seen among SARS as well. And we've seen the long-term outcomes have been predominantly around psychological issues, pain and fatigue and depression. So these are, and disordered sleep, these are still issues that are affecting us. And even with COVID, the data that's come out from the new studies in Lancet earlier this year shows that fatigue is the overwhelming problem. And that's been borne out in the reports that have come in the UK with regards to long COVID. The UK has really led the way in bringing out government-based official research far faster than any other country, as we are aware. We had a National Institute of Healthcare research report in October of last year, which identified that long COVID may actually be a constellation of 4 different syndromes, people having come out of ICU, people having organ complications, a group of people having fluctuating symptoms, and people having that post-viral fatigue, which we are aware of from other epidemics in the past. But the common symptom group is fatigue, pain, shortness of breath, brain fog, mental health, and GI and cardiac. So any service we wanted to set up needed to at least take and look after these 6 or 7 main things. And our guidance from December 2020 of NICE actually gave us the support to say that anything beyond 4 weeks could technically be called long COVID or long haulers, as it is known in the US. And we had a series of official guidelines that came out over the last 5-6 months, which has been really helpful for the UK to take a leapfrog in setting up services, in having a central understanding of what those services should look like, what the specifications of such service should look like, and how it should support patients. And I think in a way, when we think about it from the pain services, as a pain physician and the lead for the pain service there, I did feel that we would be in prime position to do it, partly because we do deal with widespread pain issues. Most pain services and pain doctors do deal with a lot of pain-related problems. We are very comfortable in looking after patients who have got multi-system issues with overlapping mental health issues. That's at least common to us there. We also are often very well integrated and linked with community services, or often we are in the community. And so we know who are the other providers and support systems in the community for our patients. And obviously, we have an MDT setup. I work with psychologists, physiotherapists, occupational therapists, nurses, and I think has a MDT setup, pain services within ISP or any other organization in any country are better served to help this group of patients, because the shortness of breath as well, we are understanding, is more of an autonomic dysfunction rather than pure structural problems. And often pain services that do this MDT approach are quite comfortable in talking about nutrition, talking about movement, lifestyle changes, behavior issues, motivation interviewing. And that's the same with long COVID. Fatigue is a big issue, shortness of breath is a big issue, but it is the psychological, it's the pain, it's the medium and long term is often pain, fatigue, and psychological issues. And so when we talked about the Berkshire Long COVID service, we made sure that we had specialists that were able to look after all this. Primary care physicians, that we had a GP, we had a secondary care, myself, we had respiratory, we had all this group of physicians and clinicians involved in the setup of a service. Plus, we had access to secondary care specialists and senior specialists in cardiology, neurology, rheumatology, and neuro rehab available to us. And we did create a service that was not only capable of assessing patients from the community who needed support, but also thinking about rehabilitation strategies. And the NHS as a whole has talked about rehabilitation, digital, offline, and online strategies. So our Berkshire Long COVID service is set up in the middle of a tier 1, which is all in the community with your primary care physicians, with all the stuff that can be done in primary care. And the tier 3, which is the really secondary, tertiary specialist support that might be needed for some people with organ complication that carries on. But for the predominant bunch of people, a long COVID service set in the intermediate or secondary care sector, or even in primary, would be the ideal way forward for supporting your patients. And we did have opportunities. We have looked at this as an integration with patients in our area. In the UK itself, it has been an opportunity to set up an integrated approach rather than the siloed ways in which we manage medical conditions. Usually, we've been able to integrate physical and mental health much more robustly in our long COVID service, and actually be aware that a lot of our patients have had a traumatic experience in many ways or the other. And so being trauma informed, being a co-production with patients, and thinking about return to work, occupational health, all of this is important, because a lot of long COVID patients are your working class people who have been fit and healthy and had full-time jobs, now struggling. So I think that needs to be brought into place with any service you're thinking of setting up. The challenges are there because this is new, because it's an integration of physical mental health. It's not sometimes how in your countries new services get set up there. It's often been difficult. Even when we set up the service, we didn't have an idea how many patients are actually out there. We set up the service in November 30th, December of 2020, we started. There are other services in the UK that started as early as May or June of 2020. And the reality is we didn't know what numbers there were that were expected. I think in your countries, wherever you are, hopefully that will be also something that will emerge, and we'll have to see as the waves come along, as the variants come along, what will be the final numbers there. And very few patients have one complaint. Most services are built around one chest pain, one thing there. We realize with long COVID, it is multiple symptoms that do need to be addressed. And sometimes we realize there's not enough new therapies are being researched, but there's nothing straight off the bat available which will help in curing the problem. So it is a new long-term condition that needs to be validated for the patient, needs to be supported, and we need to walk the journey with them, find ways on how we're going to fund non-drug mind-body therapies, and do the research along with understanding what's the difference between hospitalized, non-hospitalized patients, and accordingly what staffing and resource implications. In summary, when we wanted to set up a service there, I think what we tried was to bring the best of what the patients had told us, because this is very much long COVID as a condition where the patient voice has been very important in setting the stages of what a service ought to provide. but it has been also a unique chance to set up a truly different model of care. MDT services are going to be key there. And I think in a way, as a takeaway, I think pain services are ideally placed in your countries, especially if you are already an MDT setup, you are really in prime position to be able to help this group of patients. My theory is that if we took this advantage now to help these patients now in the early phase and help them make changes, we might be able to prevent them from 1 or 2 years down becoming diagnosed with widespread pain and other issues. So I would encourage all of you to look at these models and to seek out my number or contact details, and I'd be happy to support in looking and how we can do this in a sustainable manner for our patients, along with our patients. Thank you.
Well, thank you for listening to this workshop. I hope all of you who've been listening in have found this useful to understand what our long COVID patients are going through with regards to pain. And you've also heard from me and my colleague Harriet, and we've been part of the core team who have set up the Berkshire Long COVID Integrated Service. We are one of the 89 such clinics in England, and we're very thankful to the IASP for giving us this opportunity to talk about our service. While the questions start sort of rolling in here, thank you, Karen and Kerry, for actually giving us your point of view and bringing it to there. I'm going to focus on probably, Kerry, in your talk, obviously our recordings for this particular set was done back in May, almost 3 or 4 months ago. Can I ask you how you've been now in these last 3-4 months? In your talk, you mentioned about supplements, you talked about how you've been using a variety of mind-body techniques. Do you want to expand a little bit on how you found supplements useful?
Yes, I was sent a paper by someone I know where they questioned whether long COVID was an assault on methyl groups. And in a long conversation with my GP, because I've had B12 problems in the past, I had B12 problems when I was 18, I questioned whether I should be taking B12. My blood tests came back that they are within normal limits, but my levels are lower than they had been previously. And another consultant in a clinic in Cambridge in the UK said that all of my symptoms were indicative of B12 problems and autoimmune disorder. So being me, I did some research and I went and found a high quality, high strength B12, cyanocobalamin to start with, and more recently methylcobalamin. And what I found is that the more of it I take, the better I feel. My brain fog is improved, my headaches, which in July had me back in A&E, with acute vestibular migraines, and my dizziness and my pain have all improved exponentially. 5 days on an increased dose, and I will notice the difference. 2 days and the people around me notice the difference of an increased dose. So that has been really interesting.
Okay, and I think your description is very much in keeping with the number of patients that we've been seeing in the long COVID service who have reported changes with use of supplements in a judicious manner. And I think, thank you for your experience with vitamin B12, because you talked about D and C3 there. And I think as an observation, I'm going to say that was a very pertinent point you made with regards to how delay in access and, what the problems that a lot of patients globally, and I guess it's the same in the UK, have had in accessing long COVID services in general. So I think that's a fair observation to make. I'm going to move on to Karen, actually, in terms of your symptoms. Again, the presentation that you made was back in May. A lot changes in 3 or 4 months' time. One of the features and one of the things I kept hearing as more patients got vaccinated is that they seem to have a double-edged effect in many patients. Some people improved, some people did not improve. What has been your experience with vaccines, Karen? Have you had all your doses?
Yeah, I've had both my doses, and my experience has been I did have effects of the vaccine. Surprisingly, I had a fever, which I hadn't had before. I had low temperatures, which I wonder if that's part of what was going on with my pain. And that's taken away a lot of the chronic pain. But so it's taken that edge away, that bit that I couldn't deal with. But what I'm finding now is that I am still doing quite a bit of self-management with moving and stuff. I joke to people that I'm a perpetual motion machine, because if I stop, it comes back. And actually, last night I had a bad night. I've had a bad week. I've done too much because I've got kids, I work, and it's very easy for that. It's almost like you can just fall off it so quickly with that self-management, because it takes, I think that's something that I didn't get across in my talk, was the self-management is it takes patients time away from them, and I don't think that's always taken into account, the amount of time you have to spend managing your condition.
No, I think that's a very fair point there. Now, your group, your campaign group, Long COVID SOS, has done so much in the last year in terms of providing that recognition, that rehab, and that ability to conduct research. I have myself sought your support on a number of occasions to get a bit more feedback into some ideas we've had. How are things progressing? Are you aware of any further new research or new avenues that the group is looking at in terms of what might be useful for services to be aware of?
There's lots of research that we are, as a group, getting involved in. So there was a study in the first round, so that the National Institute for Health Research in the UK and the UK Research and Innovation have done 2 funding rounds in long COVID. We have representation on one of the first studies that was supported, the TLC Therapies for Long COVID study that's being run from the University of Birmingham. We also have involvement with, one of our members is a co-applicant on the UCLH successful bid from the latest round of funding. So we have been feeding into a lot of these clinic things, and one of the things that we are finding actually is the setup of the clinics is very different. So some people will have more active involvement and more active follow-up, where there's some people who are having a very much more hands-off approach. And actually, from a patient perspective, some of the terms that the doctors use in that aren't the most beneficial, because I think it's not appreciated that even if they can't be actively involved, that patient still needs support from somewhere, and they don't see that medical support not being needed it just means that they can't manage the condition because there's nothing known by the research right now. So I think there's a language barrier, as Kerry mentioned in her talk, that would be good to sort of break down a bit more.
I think you're right. I especially loved Kerry's use of that stickman communications model there. And I think you make the same situation with regards to how we should be communicating better there. Specifically at the long COVID services as well, we've had that same issue. And I think it's the balance which every service in every country that's trying to set up will have to get that balance between what the funders and what the doctors want to think of in terms of setting up a service, the physicians and clinicians, versus what the patient's needs are. And I think this is a balance we can only address if we have patients being involved in a more active capacity. You're right. I think it's a challenge in itself there. Thank you, Karen, so much for your input and for agreeing to help out with this. Harriet, I just wanted to come to you and actually say, now it's again been sort of 3 or 4 months have gone on. There's a lot of changes that have happened since we recorded this talk there. One of the constant themes that comes from a lot of patients is this concept of pacing. Now, everybody's talked about it there. From a physio perspective, can you enlighten us really how your understanding of fatigue and pacing has changed with regards to pain? And have you had to make any changes when it comes to managing that same concept in long COVID? What are your thoughts? What do you think?
Yeah, so we've always used pacing in all parts of our pain management strategies. I think it's really important. I think particularly with long COVID, it's come to the forefront even more because of the fatigue element associated with the pain as well. And the importance of almost that stabilization period. So before we can consider increasing activity, as Kerry and Karen have talked about, is finding that balance of everyday life that feels manageable in some really difficult situations, whether, as you said, work, children, social life, social expectations, just trying to find that balance within their own lives of what is manageable for my pain and fatigue levels at the moment. Some brilliant resources out there at the moment for helping with pacing. The Long COVID Physio website, occupational therapy website in the UK have got some good ideas on it. But I think, as Karen says, it requires a little bit of support with that. And I think that's what we've mostly been doing within our therapies team, as much as we possibly can, is supporting someone through that journey, because it's not easy. But I think that's probably for me, that's one of the most important things to start with, is how much balance has this person got in their life, and other activity levels manageable for them at the moment. And if not, how can I help support them with that? What feels okay for them at the moment?
And specifically, this is something that we've talked about in the context of pain services. As I mentioned in my talk as well, I thought pain services were in a particularly better place to take on this role of supporting these patients. Specifically, as my physiotherapy lead for this service here, how much has been the challenge in upskilling yourself in looking after breathlessness? Because that's something pain patients or within pain services we don't see, and that sometimes can worry clinicians, saying that may not necessarily be their expertise. You've had to make that change in the last 7-8 months in understanding the causes of breathlessness and supporting and talking about it to patients who are dealing with fatigue and breathlessness and pain. How easy is it, do you think, for other physios?
I think it's really difficult. I think because long COVID presents in such a variety of ways and affects people in very many different ways, I think that's really difficult. I think we're very lucky within the Berkshire Long COVID service that we've got very good colleagues in our respiratory service, and we've got very good connections there that we can always ask questions of. They've done plenty of teaching with us. They've given us lots of resources, but I suppose it's just knowing what is within your limits of knowledge at the moment. When do we need to ask the doctors, our respiratory colleagues, our respiratory physios? When might we need their advice, their opinion? Most importantly, what is the person sat in front of us, the person that's come in for help within our clinic, saying is really important to them? What are they worried about? Because again, if they're really worried about that breathlessness, it's really important we address that within the clinic. So yeah, I think it's been important that I've upskilled myself in that area, but also important to know that I've got some really good respiratory colleagues that can certainly help with that side of things. And I think they've probably upskilled with the fatigue and the pain side of things as well to do the same.
Fair enough. Thank you so much, Harriet, there. So one of the things that probably Kerry asked me initially before we started this workshop here is, given that we had all recorded a lot of this when the education series was going to be broadcast much earlier, 3-4 months ago, was to actually get an overview as what else has changed when we're looking at long COVID and pain. And I think both from mine and Harriet's perspective, we've realized that in understanding some of the biological underpinnings, and there has been an excellent article, and I would probably ask all of you in the audience to check out the British Medical Journal. This was just released about 3 weeks ago by Harry Crook and his team from London, I think from the United Kingdom, really. I'm not sure which part of the UK there, but it was an excellent overview of long COVID, and it also covered some of the aspects around pain. And that would be a good review summary resource for many of you to take away and to download. It's open access, so definitely I would signpost you all to there. Before I sort of ask Harriet also to think of some resources there, my takeaway on pain and long COVID right now, the understanding is that within the IASP definition there from 2019, where we've now understood that there are 3 categories of pain. You know, we always had the nociceptive point, we've had the neuropathic pain there, but what we are now realizing and what IASP brought out in 2019 was this 3rd category of nociplastic pain. And nociplastic pain indicated an upregulation within the central nervous system, and it has been called sometimes central sensitization. And my understanding is that a lot of pain within long COVID that is perceived by a lot of patients, and they have widespread muscle aches, joint pains there, often their blood results and inflammatory markers come back as normal, but there's no denying the extreme fatigue and generalized aches and pains they describe. So I would suggest that these are all a typical example of nociplastic pain that we are seeing within long COVID. It's quite relevant for a lot of pain services to understand this, because then trying to apply the principles of managing with nociceptive pain, you know, if you try to give medications, you do end up finding that the side effect profile may be high and patients may get unacceptable side effects. Similarly, these are not very responsive to the neuropathic drugs or even interventions, because often these are due to an upregulation within the central or peripheral nervous system. So focusing on other techniques, like a lot of our patient partners here, both Kerry and Karen commented, looking at lifestyle approaches, looking at diet and nutritional vigilance, as Kerry called it, looking at sleep and the importance of understanding sleep and optimizing sleep using wearables and trackers, and looking at physical activity and pacing as a very essential strategy is going to be the mainstay of managing the nociplastic pain that is inherent in long COVID. So that's something that we have learned as a long COVID service, that after doing 8 or 9 months, we've seen about sort of 800 referrals. We've had about more than 600 patients to our service. And although pain has been present in 65% of these patients, as per our data from March or April, we realized that most of these patients are not keen to go on the neuropathic drugs or even getting benefit from the simple analgesic drugs. They are getting often more benefit from their symptoms by other activities of lifestyle and general health and food and sleep and optimizing those things. So this is something as a learning point for a lot of you who might be having patients and looking after long COVID. Harriet, as a sort of takeaway point, I should look for some more questions there, but what do you think are the resources that you can signpost our colleagues and our patients to from at this point of view?
I really like the longcovid.physio website. I think it's got a really good amount of information on there. I think it's got lots of links to click on there as well. So that's personally one of the ones that I would use if I was to give one.
Okay, thank you so much. Kerry and Karen, any final thoughts there? Karen, shall I start with you? Anything that you would be wanting to recommend as a resource for clinicians watching this workshop to know how to look after their long COVID patients?
I would really stress to listen to the patient and how they term their pain and how they discuss it, and work with them as like kind of partners in their treatment, because different people have different ways of doing it. I saw in Harriet's that she had this diary. I'm appalling at diaries. I don't like focusing on what I've been doing. I just need to have the the kind of wide aspect of triggers. Other people really like that kind of analytic level of detail, and it's all about helping that patient and with their pain.
Thank you, Karen, so much. Kerry, what would you feel? I think you've made some very powerful comments in your slides in terms of what needs to change. 3 or 4 months down the line, what do you feel are further points that clinicians need to be aware of when helping people with chronic pain and long COVID-related pain?
I don't think it's anything additional except to reinforce the need to upskill in terms of their communication skills, be it counselling and listening skills, be it coaching and questioning skills. I think those are really important. And there's lots and lots of accredited coach training out there now that will teach clinicians how to do that. I've had the privilege of assisting in coach training before, and we've had medics in the training for coach training and neurolinguistic programming training. And the comments that come back are, this should be taught in medical school. So I would highly recommend that clinicians be looking in that direction. Definitely.
Thank you, Kerry. And I would definitely agree with that. I think as a pain service, we all in my unit, which is about 10 or 15 of us, the MDT team of nurses, physician colleagues, physiotherapists, psychologists, and other allied health professionals, we all underwent a motivational interviewing course there. So I think I would definitely second Kerry's suggestion that trying to upskill ourselves in coaching strategies and techniques to work with our patients is going to be a very transferable and essential skill for all pain services. I think there have been no major questions that have come through from there. I hope that this has been a very useful workshop for all of you with regards to long COVID pain and understanding the patient perspective and what services can pivot around to provide for these patients. So thank you so much for listening today on the final day. I wish you all a very good weekend, and over and out from the United Kingdom here. Thank you. Bye.